This recording will go over assessment of coronary artery disease. There's no slide for this portion, so you'll want to follow along in your book and also take notes. If symptoms of coronary artery disease are present at the time of the interview, delay collecting data until interventions for symptom relief, vital sign instability, and dysrhythmias are started and discomfort resolves. If the patient had pain, ask about how he or she has managed the discomfort and other symptoms and which drugs he or she may be taking. When the patient is pain-free, obtain information about family history and modifiable risk factors, including eating habits, lifestyle, and physical activity levels. Ask about a history of smoking and how much alcohol is consumed each day. Collaborate with the dietitian to assess current BMI and weight as needed. In regards to physical signs and symptoms, rapid assessment of the patient with chest pain or other presenting symptoms is crucial. It is important to differentiate among the types of chest pain and identify the source. Question the patient to determine the characteristics of the alterations in comfort. However, patients may deny pain and report that they feel pressure. Appropriate questions to ask concerning the discomfort include onset, location, radiation, intensity, duration, and precipitating and relieving factors. If pain is present, ask the patient if pain is in the chest, epigastric area, jaw, back, shoulder, or arm. Ask the patient to rate the pain on a 0 to 10 scale. Some patients describe the discomfort as a tightness, a burning sensation, pressure, or indigestion. Many women of any age experience atypical angina. Atypical angina manifests as indigestion, pain between the shoulders, an aching jaw, or a choking sensation that occurs with exertion. These symptoms typically manifest during stressful circumstances or ADLs. Women may curtail activity as a result of angina, and healthcare providers need to ask about changes in routine. Symptoms in women typically include chest discomfort, unusual fatigue, and dyspnea. Please review Chart 38-2 for key features of angina and myocardial infarction. Because angina pain is ischemic pain, it usually improves when the imbalance between oxygen supply and demand is resolved. For example, rest reduces tissue demands, and nitroglycerin improves oxygen supply. Discomfort from an MI does not usually resolve with these measures. Ask about any associated symptoms, including nausea, vomiting, diaphoresis, dizziness, weakness, palpitations, and shortness of breath. Assess BP and heart rate. Interpret the patient's cardiac rhythm and the presence of dysrhythmias. Sinus tachycardia with PVCs frequently occur in the first few hours after an MI. Next, assess distal peripheral pulses and skin temperature. In the patient with unstable angina or MI, poor cardiac output may be manifested by cool diaphoretic skin and diminished or absent pulses. Auscultate for a S3 gallop, which often indicates heart failure, a serious and common complication of MI. Assess the respiratory rate and breath sounds for signs of heart failure. An increased respiratory rate is common because of anxiety and pain, but crackles or wheezes may indicate left-sided heart failure. Assess for the presence of jugular venous distension and peripheral edema. The patient with MI may experience a temperature elevation for several days after infarction. Temperature as high as 102 may occur in response to myocardial necrosis, indicating the inflammatory response. Denial is a common early reaction to chest discomfort associated with angina or MI. On average, the patient with an acute MI waits more than 2 hours before seeking medical attention. He or she rationalizes that symptoms are caused by indigestion or overexertion. Fear, depression, anxiety, and anger are other common reactions of many patients and their family. In regards to laboratory assessment, although there is no single test to diagnose MI, the most common laboratory tests include troponins T and I. Troponin is specific for MI and cardiac necrosis. Troponins T and I rise quickly. If you remember from previous lecture, troponins are usually drawn more than once because the patient may come in with a normal troponin level that increases with time. So you'll hear in the clinical setting of patients having a serial troponin being drawn. Unless there is associated cardiac dysfunction such as valve disease or heart disease, a chest X-ray is not diagnostic for angina or MI. A chest X-ray may be performed to help rule out aortic dissection, which may mimic an MI. Thallium scans use radioisotope imaging to assess for ischemia or necrotic muscle tissue related to angina or MI. Areas of decreased or absent perfusion, referred to as cold spots, identify ischemia or infarction. Contrast-enhanced cardiovascular magnetic resonance, or CMR, imaging may be done as a non-invasive approach to detect CAD. Echocardiography may be used to visualize the structures of the heart. Use of CT coronary angiography has been found to be helpful in diagnosing CAD in symptomatic patients identified as having low or intermediate pretest probability risk for CAD. 12-lead ECGs allow the healthcare provider to examine the heart from varying perspectives. By identifying the lead in which ECG changes are occurring, the healthcare provider can identify both the occurrence and the location of ischemia and necrosis. In addition to the traditional 12-lead ECG, the healthcare provider may request a right-sided or 18-lead ECG to determine whether ischemia or infarction has occurred in the right ventricle. The ECG should be obtained within 10 minutes of the patient presentation with chest discomfort. An ischemic myocardium does not repolarize normally. Thus, 12-lead ECGs obtained during an angina episode reveal ST depression, T-wave inversion, or both. Variant angina caused by coronary vasospasm usually causes elevation of the ST segment during angina attacks. These ST and T-wave changes usually subside when the ischemia is resolved and pain is relieved.